Yes, they do. Fractionally, they do. But when they do, you have to calculate what is the ejection fraction like. If it is lesser than 50%, then you have to consider that whether it's a classical low flow, low gradient, or whether it is a pseudo aortic stenosis or no aortic stenosis at all. We are going to just talk about this. There is yet another condition called the paradoxical low flow, low gradient. So this is another very interesting thing which the world has started talking about. Severe aortic stenosis, low flow, low gradient, normal LV. Now this is a little bit of a paradox, but yes, it happens, and that's the reason why it is called paradoxical low flow, low gradient aortic stenosis. Then there is normal flow and low gradient. I'm going to highlight only on classical low flow, low gradient aortic stenosis. Now, why is it so important? Because once you have that kind of a low flow, low gradient, the problem with lesser of gradient does not translate into these as survival benefits. We know from this study that larger the gradients, lesser is the survival. But what if you don't get large gradients? It could be non-technical reasons also. And this is one of the reasons that in a poor LV, there is a contractility issue which kind of upsets the whole phenomena and goes on for low ejection fraction, not giving enough and more pump to the LV. Here is what it is. So there is a supply-demand mismatch whenever there is a hypertrophic cardiomyopathy kind of a situation where there is a LV hypertrophy in aortic stenosis. There is a supply and demand mismatch, which actually is because of leads to a reduced capillary density, leads to chronic subendocardial ischemia, leads to interstitial fibrosis, and there is a afterload mismatch because the LV is not able to pump that much more. So high gradient severe aortic stenosis may translate or get converted into classical low flow, low gradient severe aortic stenosis because the LV is not able to pump that much of blood and it is not able to generate that much of gradients.
Make it full screen.
It can't.
Oh, okay.
That's the problem. So this is paradoxical low flow, low gradient. In paradoxical low flow, low gradient, what is happening is because of the hypertrophy per se, there is so little of blood which is entering into the LV, and when it ejects out, it does not get ejected out with that much of gradient. So there are three reasons why paradoxical aortic stenosis have been propagated. What are the reasons for it? One is lesser quantum of blood entering into a very hypertrophied ventricle, and when it compresses, it does not eject out blood with that gradient. One. Second is that maybe the initial ejection fraction was 70% or they were supernormals. And when they were supernormals and when the LV has started deteriorating, the gradients have come down, and that is the reason why many of these paradoxical aortic stenosis may be a forma frusti of classical low flow, low gradient, where the ejection fraction from earlier 70% or so has come down to about 55%, and we think that it is normal LV. Third is that hypertension, whenever it is happening, with presence of high afterload, the gradients come down. So these are three hypotheses why paradoxical aortic stenosis, low flow, low gradients occur. I am going to talk about this in particular because this is what is the topic for the day. Dobutamine stress echo with positive LV flow reserve. So what we are trying to calculate is effective orifice area. And when you do dobutamine, you have to differentiate whether it's a true severe AS or a pseudo severe AS. So if there is a little or no change in area with increase of gradients on low dose dobutamine, increase of gradients you have to document, and this will translate into a true severe aortic stenosis. However, if there is a pseudo severe AS, there will be no change. In fact, paradoxically, the effective orifice area can be higher, and the gradients will come down. So this is how you differentiate, and there is the importance of dobutamine stress echo. So this was a very interesting study where there were two groups of people who were taken. The patients with LV flow contractile reserve, which was calculated on dobutamine stress echo, which was defined as 20% increase in stroke volume during dobutamine stress echo. And they have a markedly reduced survival if there is no contractile reserve as compared to those with LV flow reserve. So these were two groups. Both groups, when compared, one group was with valve replacement, another group was with medical therapy. So the group which had a good contractile reserve continued to do better when they compared themselves with the other peers. And this is regardless of what therapy they followed. So this is one landmark study which said that when you have a low flow, low gradient, if you want to really prognosticate, then dopamine stress echo probably is by far the better. Now, this is a study which is awaited. This is true or pseudo aortic stenosis to pass trial, in which they have tried to calculate something beyond. They have calculated several things, because the biggest debate the world faces is to do or not to do, because you do it and the risk factors are very high. Fortunately, lesser risky procedures like TAVR have come, but for all practical purposes, if you really want to be truthful to the patient that this is what the disease is and this procedure is going to benefit you definitely or not, because most of the times when poor LV is there, you're not sure whether the patient will translate into benefit over a period of time or not, unless you have documented a very good contractile reserve. So this is the study which we are all awaiting for, in which there is a dopamine stress echo, and plus what they are doing is that they have given a constant calculated the effective orifice area with constant normalized flow rate of 250 ml per second of saline. And they have suggested that if the calculated aortic valve area is lesser than 0.8, probably this is probably a very beneficial thing. Now, this is a true case and very interesting. This was a patient post-bypass surgery with severe LV dysfunction, with dysfunction with recurrent hospitalization for heart failure. Now, this was a big issue. So, this is poor LV, like you can see, and there is a calcium which is high, and we were kind of debating whether to do something else other than that. Recurrent heart failure, we didn't have Vericiguat at that time. He was on all 4 drugs for heart failure. Nothing could have come, but we knew that we are dealing with a calcific aortic stenosis. Whether it was severe or not, we didn't know. Nobody knew. Unfortunately, I don't think it is going to play, but let me just try. So we did 4-chamber. This 4-chamber showed, let me just come, since it's not playing, I'll come to the, this is short axis. Now again, the short axis showed that there was an area of about 0.77. Unfortunately, we didn't know that whether this was a truthful stenosis or whether because of poor LV it was not able to contract and open up the leaflets too well. So this is always a debate which continues. So we did some calculations here. If you look at this, the mean PG was 1 across LVOT. We tried to calculate the aortic valve area by continuity equation, and we found that the continuity equation was 1.10, 1.11. Now again, non-critical, should you do it, not do it, how to do it? Again, the debate continued, and what we did was, we left it for the time being, discussed it in our heart team. Heart team is a very important component in any institute where they are doing these complex cases. So, heart team said that this is not a critical stenosis, what to do? Mean PG across aortic valve was 15 millimeters of mercury. LE is so dilated, whether it will recover or not. Global ejection fraction. And that is the time in that heart team, we had invited the patient's relatives also, and they said, listen, regardless of whatever you can do, do it. Money is no consideration. So we took the patient for transesophageal echo, very difficult transesophageal echo, difficult imaging. And ultimately what we did, 3D. Unfortunately, what happens is, if you don't have a good 2D, you'll not have a good 3D too. So rubbish in, rubbish out. 3D, since we didn't have a 2D image, our 3D images were also rubbish. We did a calcium scoring. And in this calcium scoring, to our surprise, his calcium score for aortic valve was 3082. Now, the cutoff for calcium scoring for men is about 2000 plus, and for women it is 1200 plus. Clearly, this patient was falling into the category where we were missing a severe critical aortic stenosis, regardless of what method we took. And now we took the patient for dopamine stress echo. Dopamine stress echo, when we did this, these are the baseline. And when we did it, we found that the gradients increased from this is the baseline 15, and the gradients increase, and the gradients increase to 29 millimeters of mercury. So from 15 it jumped to 30, and then we were pretty sure that we must do something, and then we put the patient on TAVR. After TAVR, you'd be surprised, the ejection fraction improved, the LV started. Here you can see that there is a valve which has been replaced percutaneously, and this is what it is. So let me just sum up with my take-home messages. Look at all the possible views. Shamelessly utilize GLS. This is especially when you are looking at a paradoxical aortic stenosis. Because in paradoxical aortic stenosis, if your ejection fraction initially was 70%, now has become 55%, your ejection fraction per se is not going to be beneficial. It is the GLS which would have shown a lot. Use 3D, use calcium scoring, and dobutamine stress care. Do it carefully and very carefully. And lastly, respect all your clinical skills. Thank you very much for a patient listening.
Thank you, Dr.
This is what the current guidelines are, where it says DSE still exists. Sorry, sir.
You're over?
I'm okay because I wish my slides were moving.